Good morning, students. Today we will discuss about systemic lupus erythematosus. It is also called commonly SLE. It is an autoimmune disorder characterized by immune complex deposition. In your hypersensitivity chapter, you have seen the type 3 hypersensitivity where the immune complex are deposited in the different organs affecting and damaging that organ. This is the main underlying cause of systemic lupus erythematosus. It is an also autoimmune disorder. The immune complexes are formed against the self-antigen. Now the etiology. Etiological factors are genetic factors, immunological factors, environmental factors. In case of genetic factors, first degree relatives are frequently affected and HLA association is also found in this disorder. It is also seen that 30% of monozygotic twins are affected and 2 to 3% of dizygotic twins are affected in these disorders. HLA-DR association is also found with this disorder, and that proves that it is a genetic factor. Now, immunological factors. In autoimmune disorders, you already seen the autoantibodies are formed when there is failure of tolerance. You have learned about tolerance. It is central and peripheral type of tolerance are there, where the self-reactive B cells and T cells are eliminated from our body. That is the tolerance. That's why the self-reactive T cell and B cell do not react with our self-antigen. But when there is failure of tolerance, the self-reactive T cell and B cell become activated and our self-antigens are affected by the antibody produced by those reactive B cells, and different types of immunological reaction, elimination of cytokines, and affect the different organs. Now, defective elimination of self-reactive B cells in bone marrow, failure of tolerance, and that produce the autoantibody. The nuclear components may engage toll-like receptors which normally function against microbial products including nucleic acid. B cells become activated and produce anti-nuclear antibodies. So here toll-like receptors in the dendritic cells and B cells both become activated. Toll-like receptors, what they do? They produce the interleukins, different types of cytokines, and the activated B cells produce anti-nuclear antibody, that is an autoantibody. Now the different types of environmental factors. These are ultraviolet rays, sex hormones, and drugs. All these are responsible for etiology of the SLE. Now the pathogenesis of SLE. There are some environmental factors and other factors causes apoptosis of cells. Inadequate clearance of the nuclei of these cells cause large burden of nuclear antigen. Failure of tolerance causes activation of self-reactive T cell and B lymphocytes. I already discussed about the tolerance, and the reactive T and B lymphocytes produce nuclear and antigenic antibody, the antibody against nuclear antigen, and these antibodies react with the nuclear material of the apoptotic cells. Now the complexes of antigen and antibody bind to the Fc receptor on B cell or dendritic cell and may be internalized. Now the nucleic acid component engage toll-like receptor and stimulate B cell to produce autoantibody. You learned about toll-like receptor in your innate immunity chapter. In innate immunity you have seen the toll-like receptors activated and causes many inflammatory reactions. Now the dendritic cell produce interferon and cytokines which further enhance immune response and causes more apoptosis. This type of inflammation causes more apoptosis and results in cyclic antigen release. Antigen means nuclear antigen, which reactivate the T and B cells, and immune activation resulting on production of anti-nuclear antibodies and other high affinity antibodies, other autoantibodies. So the autoantibodies are produced against mainly the nuclear material and the other also many other antigenic components. Now you see the diagrammatic picture of pathogenesis, where the apoptotic cells release the nuclear material and autoantibodies are produced by the B cells, and the toll-like receptors activated. They produce interferon and ultimately autoantibodies are produced and recruitment of inflammatory cells by the different types of cytokine and causes tissue injury. Now the mechanism of tissue injury in SLE. Autoantibody is formed. Formation of immune complex with antigen and autoantibody, self-antigen and autoantibody. With there are some components of complements are also there, and low level of complement due to consumption in immune complex. Low level of complement in serum due to consumption of complement in the immune complexes. Now the deposition in the different organs causes damage to the different organs. Autoantibody to the RBC, WBC platelet causes opsonization of the cells and helps in phagocytosis. Now the anti-nuclear antibody can only bind with nuclear component of the damaged cell, lose their chromatin pattern, becomes homogeneous and produce so-called SLE bodies. Now what are the SLE bodies? SLE bodies are the nuclear material damaged by the anti-nuclear antibody and which is homogeneous, and this type of cell is called SLE body. SLE cell is phagocytic leukocyte that has engulfed the denatured nucleus of an injured cell. Now what is the SLE cell? SLE cell is the phagocytic leukocyte that has engulfed the denatured or homogeneous nuclear material of an injured cell. This is also a schematic presentation of SLE pathogenesis. Now what are the different types of antibodies in lupus? That is anti-nuclear antibody, double-stranded DNA, anti-Smith antibody, anti-RNP, ribonucleoproteins, anti-SSA, anti-SSB, anti-cardiolipin, anti-B2 glycoprotein. This name of these antibodies you have to remember. Now what is anti-nuclear antibodies? Antibodies that bind to various antigens in the nucleus of a cell. And how is it measured? Indirect immunofluorescence. Indirect Now you see immunofluorescent pattern, different pattern of ANA. Now the different types of Clinical criteria. First is malar rash. Next, discoid rash. I will show you later. Now the photosensitivity. That is the sensitivity against sun ray or any types of UV rays. Oral or nasal ulcers. Arthritis, joint inflammation. Serositis, that is pleuritis or pericarditis, etc. Renal disorder, the proteinuria more than 500 gram per day, and the different types of cells, RBCs mainly, may be found. Casts also may be present. Now the immunological criteria, that is the anti-SM antibody, anti-dsDNA antibody, anti-cardiolipin antibody, etc. Hematological, anemia may be present, leukopenia and thrombocytopenia. Now next is the neurological manifestation. Seizures or psychosis may be present, and positive anti-nuclear antibody in absence of drugs. Now we see, this is the picture of malar rash. This is the discoid lesion. Scarring ulcer over the scalp, face. Now oral ulcer. Now what exactly is lupus? That is the autoimmune disease where one's immune system attacks first. Autoantibody production, immune complex deposition, inflammation and damage. It is a chronic disease characterized by flares and remission. Pleomorphic with different phenotypic expressions. Multi-system is involved. So, this is an autoimmune disorder, multi-system involved. It sometimes flare ups and sometimes patient may stay in remission phase, and different types of phenotypic expression may occur. Now different types of lupus: drug induced lupus, neonatal lupus, cutaneous lupus and systemic lupus erythematosus. So the systemic lupus erythematosus is mostly important, but we have to differentiate it from the drug induced lupus, where there will be some history of drug intake of different drugs. Drug induced lupus, approximately 80 offending drugs can cause lupus. 15,000 to 30,000 causes reported annually. Production of autoantibodies more common than clinical symptoms. 99% disappears within 3 months of stopping the medicine. Now this is the difference between drug-induced lupus and systemic lupus. We go through this. Most important is anti-histone antibody is present mostly in case of drug-induced antibody. In case of 90%, you will get anti-histone antibody. And the ANA is also very sensitive. It is sensitive for all types of lupus. But anti-histone antibody is specific for the drug-induced lupus. And here the male-female ratio is 1:1 in case of drug-induced. But in case of systemic lupus, the females affected more. The female is to male ratio is 9:1. And other clinical manifestations are less than the systemic lupus erythematosus in case of DI. Different type of drugs affecting the DIL, drug-induced lupus, procainamide, hydralazine, minocycline, diltiazem, penicillamine, INH, quinidine, etc. Now, laboratory findings of systemic lupus erythematosus: 97% positive anti-nuclear antibody, 61% present with low component level C3 and C4, 50% present with double-stranded DNA antibody, 46% present with leukopenia, 42% present with anemia, 40% with proteinuria nephritis, 35% anticardiolipin antibodies, 25% Sjogren syndrome with positive SSA/SSB, 12% pleural effusion, and others are the thrombocytopenia, anti-SM antibody, anti-RNP antibody, elevated LFT, splenomegaly, thrombophilia, miscarriage, etc. Now come to the morphology. Most characteristic lesions result from immune complex depositing in blood vessels, kidney, connective tissue and skin. Most important, you have to know mostly the kidney manifestation. It is also called lupus nephritis, affected up to 50% of SLE patients. Immune complex deposition in glomeruli, tubular, peritubular, capillary basement membrane or large vessels. Now, thrombi in the glomerular capillary arterioles, often associated with anti-phospholipid antibody. Mostly DNA, anti-DNA antibody is formed. A morphological classification is there. It is class 1 lupus nephritis is minimal mesangial, class 2 is mesangial proliferative, class 3 is focal proliferative, class 4 is diffuse proliferative, 5 is membranous. So this is the morphological classification of lupus nephritis. This is the class 4, where you get loop pattern of glomerulonephritis. In skin, hydropic degeneration of basement membrane, immune fluorescent microscopy show immune complex depositing along the dermoepidermal junction. Joints, here the non-erosive synovitis. In contrast to rheumatoid arthritis, little deformity is seen where in rheumatoid arthritis, but in case of SLE arthritis, no deformity is or little deformity is seen. CNS, antibodies against synaptic membrane protein and serocytes is also present. In CVS, pericarditis, acute, subacute or chronic, myocarditis causes ECG changes, valvular endocarditis, non-bacterial verrucous endocarditis, spleen, splenomegaly may be found, lungs, pleuritis, pleural effusion are most common. To see the different organs affecting CNS, skin, blood, in serum antibody you can find in kidney, glomerulonephritis, arthritis, splenomegaly, etc. Now the topic is rheumatoid arthritis. It is a chronic systemic inflammatory disorder. Principally attacks the joints, producing non-suppurative progressive inflammatory synovitis that progress to destruction of articular cartilage and ankylosis of the joint. Now what is ankylosis? Ankylosis means narrowing of the space of joint. It may be fibrous or it may be osseous. Later on we will discuss about ankylosis. It is a systemic inflammatory disorder. It also affects skin, blood vessels, heart, lungs, and muscle. Now there are different etiological factors behind this disease, but mostly the autoimmunity factor lies behind the chronic inflammatory process. As we discussed in the previous topic, that is systemic lupus erythematosus, the autoimmunity ultimately leads to inflammatory process. Here also the autoimmunity, the disease starts with autoimmunity factor and leads to chronic inflammation. And exposure of genetically susceptible person to an arthritogenic antigen, that starts the disease process. And with some other factors, genetic factors, environmental factors, the disease ultimately leads to chronic inflammation. Now autoimmunity, 80% of the individual with rheumatoid arthritis disease have autoantibodies to Fc portion of autologous immunoglobulin G, and these autoantibodies are of IgM type, and it is also called rheumatoid factor, which is the diagnostic factor in the rheumatoid arthritis. Now in pathology, changes are caused mainly by antibodies against self-antigens and cytokines mediated inflammation. As I have told, the autoantibodies develop and different types of cytokines with the help of CD4 T cells. This is the principal source of the cytokine and causes the different inflammatory reactions to the different part of the body. In rheumatoid arthritis, antibodies developed against the citrulinated fibrinogen, type 2 collagen, alpha enolase and vimentin, etc. The immune complexes that deposit in the joint, and these antibodies are the diagnostic marker for the disease and may be involved in the tissue injury. These autoantibodies we have to investigate it for the diagnosis of rheumatoid arthritis. First is the rheumatoid factor and second is anti-citrulinated protein, anti-CCP. Now this is the pathology process of the rheumatoid arthritis. Some anti-arthritogenic antigen presented through the antigen presenting cell, and genetic susceptibility causes the expression of MHC class 2 and involve the CD4 T cells. Now different cytokines released from CD4 T cells, B cell activated, and formation of rheumatoid factor and other antibodies. This immune complex formation and deposition in the different part of the body and also in the joint causes the joint injury. Next, activation of the macrophage causes the liberation of different type of enzyme, collagenase, stromatolysine, elastase, etc. causes further erosion of the joint space. Activated macrophage release some cytokines, tumor necrosis factor, interleukin 1, also activate the fibroblast, chondrocyte, synovial cells. These also causes release of different types of enzymes and ultimately causes destruction of the joint. Cytokines have also role on the endothelial cells, and activation of the endothelial cells causes expression of adhesion molecules, accumulation of the inflammatory cells, and ultimately there is chronic inflammatory process goes on and destruction of the joint occurs with formation of pannus. Later we will discuss about the formation of pannus. And what is pannus? Now, the morphology. As the joint is mostly involved organ in this disease, so we discuss about the joint first. The synovium is grossly edematous, thickened, hyperplastic, covered by bulbous fronds. Now, histologically, we get perivascular inflammatory infiltrate. The inflammatory cells are CD4 T cells, plasma cells, macrophage, etc. Vascularity is increased. Fibrin covering the synovium. Accumulation of neutrophils and the osteoclastic activity increased in the juxta-articular bony tissues. Now, ultimately, pannus formation occurs. And what is pannus? Pannus is a mass of synovium and synovial stroma consisting of inflammatory cells, granulation tissue, and synovial fibroblasts. It causes destruction of articular cartilage, destruction, and forms the bridge that oppose two articular spaces. First, it causes fibrous ankylosis and then causes bony ankylosis. So, this bridge formation occurs through fibrous tissue in case of fibrous ankylosis and through bony tissue in case of bony ankylosis. Ultimately, the joint space narrowing occurs. So, the pannus is the pathognomonic feature in joint involvement in case of rheumatoid arthritis. Now, you can see in the left hand side there is a normal joint space with synovial membrane, cartilage, capsule, etc. But in case of rheumatoid arthritis, synovium is inflamed. Synovial fluid contains different cells, mainly the neutrophil. And formation of pannus, where the major cell types T lymphocyte, macrophage, and minor cell types are the fibroblast, plasma cells, endothelial cells, dendritic cells, etc. Now you can see the deformity of the joint occurs in case of rheumatoid arthritis, and here is a difference of joint involvement in case of rheumatoid arthritis. The difference of joint involvement in case of SLE is that in case of SLE there is little deformity or little erosion of the joint occurs in case of SLE. But in case of rheumatoid arthritis, the small joints are involved and there is large deformity and erosion in the joint space occurs rather than in case of SLE. So in case of SLE, the joint involvement is arthritis is non-erosive. But in case of rheumatoid arthritis, the arthritis is erosive in nature. Now the skin involvement in rheumatoid arthritis. Rheumatoid nodules are the most important cutaneous lesion. Occurs in 25% of affected individuals, especially in severe disease, and arises in the area that are subjected to pressure. So, where pressure effect is present, the nodules appear in that area. What are the areas? That are the ulnar aspect of forearm, elbow, occiput, lumbosacral region, etc. Nodules are firm, non-tender, and round to oval, and arise in the subcutaneous tissues. Microscopically, they have central zone of fibrinoid necrosis, surrounded by epithelioid histiocytes, lymphocytes, and plasma cells. Now, these are the nodules arising in the elbow, ulnar aspect, lumbosacral region, etc. Now the clinical course. The clinical course is extremely variable. Generally have an insidious course, starts with malaise, musculoskeletal pain, and joints are involved later. Very slow progression of this disease occurs generally. Pattern of joint involvement is symmetrical and small joints are affected more than the large joints. Joints are swollen, warm, painful after arising or inactivity. So, after arising in the morning, we can the stiffness morning, that is called the morning stiffness of the joint. A progressive involvement occurs. The disease course may be slow or rapid. X-ray finding, joint effusion, juxta-articular osteopenia, that is osteoporosis, with erosion and narrowing of joint spaces with loss of articular cartilage. In case of laboratory investigation, we detect RA factor and anti-CCP antibody. So, these are the diagnostic criteria of the rheumatoid arthritis. The RF, what is the RF factor? I have told previously, the autoantibody against Fc portion of immunoglobulin G, and this autoantibody is IgM type, and anti-cyclic citrullinated peptide, that is another antibody. These two antibody we detect for diagnosis of the rheumatoid arthritis. So, thank you.